Welcome to this Step 3 review on the most common complications you will see in the intensive care unit. This video is brought to you by Roadmap to Residency. The intensive care unit is a favorite setting for board questions because the patients are complex and the right next step is often a matter of timing and source control. Our goal today is not to reteach all of critical care. It is to show you how these question stems are built and how to attack them quickly. Make sure you are also working through your question bank and a trusted critical care review resource alongside this video, because these patterns are best learned by doing many practice questions. Let us get started. Here is our plan for the next several minutes. We will focus on 4 high-yield intensive care complications: ventilator-associated pneumonia, infections related to central lines, intensive care delirium, and the weakness that follows a long critical illness. For each one, we will learn the signature of the question stem, the test-taking strategy that points you to the answer, and then we will work through full multiple-choice questions and explain why each option is right or wrong. Remember, this video is about strategy and pattern recognition. To truly learn the underlying medicine, pair it with your question bank and a trusted critical care review resource, and read every answer explanation as you practice. Our first strategy is about anchoring. Before you do anything else, find 2 pieces of information in the stem: the number of days the patient has been on support and the devices that are attached to the patient. Intensive care complications are timed events. New fever and worsening oxygen exchange after about 2 days on the ventilator points you toward ventilator-associated pneumonia. New confusion several days into an admission points toward delirium. Weakness that appears only after a very long stay points toward critical illness weakness. And whenever you see a central catheter or a breathing tube mentioned, ask whether that very device is the source of the new problem. The day count and the device are almost never background detail. They are the test writer pointing you straight at the answer. Our second strategy is about the order of operations for infection and for confusion. When a critically ill patient who is not in shock develops a new infection, the exam rewards obtaining cultures first and then starting empiric antibiotics. Drawing blood from both the catheter and a separate peripheral vein before antibiotics is a classic correct answer. The second half of this strategy is source control. The best answer often means removing the infected line or fixing the trigger, not simply adding another drug. For delirium, the first move is to find and reverse the cause, not to reach for a sedative. Keep these 2 ideas close. Culture before antibiotics, and control the source before you escalate medication. Before we start the questions, let us name the 3 answer choice traps that catch people on these stems. The first trap is reaching for advanced imaging when the simple bedside workup, the cultures and the chest film is what actually changes management. Start cheap and simple. The second trap is the sedative reflex in delirium, where the tempting wrong answer is to immediately sedate or restrain instead of searching for a reversible cause and using non-drug measures first. The third trap is the overkill workup for weakness, where the stem of a patient who is weak after a long stay tempts you toward urgent brain imaging or a spinal tap, when the answer is simply to recognize critical illness weakness and support the patient. Keep these 3 traps in mind and the questions become much easier. Let us work through our first practice question on ventilator-associated pneumonia. A 60-year-old man has been on the ventilator for 4 days after surgery for a perforated bowel. He now has a temperature of 39 degrees, a rising white blood cell count, and thick yellow secretions from his breathing tube. His oxygen requirement has climbed over the past day, and a chest film shows a new patch of opacity in the right lower lung. The question asks for the most appropriate next step. Your options are: obtain a lower respiratory culture and begin empiric antibiotics, order computed tomography of the chest before any treatment, remove the breathing tube and observe, or simply give acetaminophen and recheck in the morning. Pause here and make your choice before we walk through it together. Let us reason through it. First, spot the pattern. A patient who has been on the ventilator for more than 2 days now has a new fever, a rising white count, purulent secretions, a climbing oxygen need, and a new opacity on the chest film. On day 4, that combination is the classic picture of ventilator-associated pneumonia. Now choose the answer. Choice A is correct. Obtain a lower respiratory culture, and then begin empiric antibiotics. The culture before antibiotics rule lets you narrow the drugs once results return. Now, eliminate the rest. Choice B delays treatment for a scan you do not need, since the chest film already shows the infiltrate. Choice C removes the tube from a patient whose oxygen need is rising, which is unsafe. Choice D treats only the fever and ignores a likely pneumonia. The answer is to culture and start empiric antibiotics. Now our second practice question, on a line infection. A 58-year-old woman in the intensive care unit has had a central catheter in her internal jugular vein for 7 days. She develops a temperature of 39 degrees and a single episode of low blood pressure that recovers with fluid. The skin around the catheter looks red, and there is no other obvious source on examination. Her chest film and urine studies are unremarkable. The question asks for the most appropriate next step. The options are: draw blood cultures from the catheter and a peripheral vein, remove the line and start antibiotics. Start antibiotics through the existing catheter and leave it in place. Exchange the catheter over a guide wire at the same site. Or simply observe without cultures. Pause and pick your answer before we work through it. Let us read the device and the clues. The stem hands you a central catheter in place for 7 days, a new high fever, a brief drop in blood pressure, redness at the insertion site, and no other source once the chest film and urine come back clean. That is the classic picture of a catheter-related bloodstream infection, and the line itself is the source. Now think about why source control wins. Choice A is correct. Draw paired cultures from the catheter and a peripheral vein. Remove the infected line because the patient had an episode of low blood pressure, and start empiric antibiotics. Choice B leaves the source in place. Choice C exchanges over a guide wire at the same site, which keeps an infected tract and is wrong when bloodstream infection is suspected. Choice D dangerously delays care. The answer is paired cultures, line removal, and antibiotics. Now let us turn to intensive care delirium, which is one of the most tested and most misunderstood topics. First, recognize the signature. The delirium stem describes an older patient, several days into the stay, who becomes acutely confused with attention that comes and goes through the day and is often worse at night. The key words are acute onset, inattention, and a fluctuating course. That pattern means delirium, not dementia, and not a primary psychiatric illness. Second, hunt the cause before the sedative. The correct first move is to look for a reversible trigger such as low oxygen, infection, pain, a full bladder, constipation, poor sleep, or a culprit medication like a sedative or an anticholinergic. Favor non-drug measures first. Reorient the patient, restore the day and night cycle, remove unneeded lines and restraints, and get the patient moving. Reserve antipsychotic medication for severe agitation that threatens safety. Here is our delirium practice question. A 72-year-old man is in the intensive care unit on his 3rd day of recovery from severe pneumonia. Overnight, he becomes agitated, pulls at his lines, and cannot hold his attention through a simple conversation. His daughter says he was sharp and oriented earlier in the day. His oxygen level, blood pressure, and blood sugar are normal, and there is no fever. He has been receiving a sedative infusion and was given an antihistamine for sleep. The question asks for the most appropriate next step. The options are: review medications, stop the offending sedating drugs, and use non-drug measures. Apply physical restraints and continue the infusions. Order urgent imaging of the head and a spinal tap. Or give a large dose of a benzodiazepine. Pause and choose before we reason through it. Let us find and fix the trigger. This is acute, fluctuating confusion with inattention in a hospitalized older man, which is delirium. The stem points you straight to the cause by naming a sedative infusion and a sleep aid that worsens confusion. So choice A is correct. Review the medication list, stop the offending sedating drugs, and use reorientation and non-drug measures to calm and support him. That treats the cause rather than masking it. Now, the distractors. Choice B reaches for restraints, which can worsen agitation and are a last resort. Choice C orders urgent head imaging and a spinal tap, the overkill trap, when the cause is already pointing at medications and there are no focal findings. Choice D gives a benzodiazepine, which deepens delirium in most patients and is reserved for special situations like alcohol withdrawal. The answer is to find and fix the trigger first. Our last pattern is the weakness that follows a long, critical illness. Read the stem. A 65-year-old man spent 3 weeks on the ventilator for severe sepsis, with days of deep sedation and a course of corticosteroids. As sedation lifts, he is awake and alert, but profoundly and symmetrically weak in all 4 limbs, with reduced reflexes and no sensory level, and his brain and spine imaging are normal. Now the answer. That signature symmetric limb weakness after a prolonged septic illness with sedation and steroids in a mentally clear patient with normal imaging is critical illness neuropathy and myopathy, also called intensive care acquired weakness. The best step is to recognize it, confirm it with examination and supportive testing, and treat with supportive care, minimizing sedation, and early physical therapy and rehabilitation. Urgent brain imaging or a spinal tap is the overkill trap, and there is no quick drug fix. Let us bring it together. You now have the 4 patterns and the strategy for each. Count the days and find the device, culture before antibiotics, control the source, hunt the trigger before you sedate, and recognize critical illness weakness instead of chasing a rare diagnosis. The way to make these automatic is to drill them in your question bank and read every answer explanation, even when you got the question right, while you reinforce the concepts with a trusted critical care review resource. If you would like personal guidance, visit roadmaptoresidency.com, where our expert tutors and residency advisors can help you build a study plan that fits you. If this video helped you, please like and subscribe for more board review content. Good luck on your exam, and we will see you in the next one.